let me formally welcome Dr. Jenin Patel, and thank you so much for taking out your time. It's been long pending. There was quite a few people asking for how to read corneal topologizer better. You see these colorful scans and then you get confused. Yes, no, refractive, cataract. So how best we can utilize these machines. So we made an attempt, and we'll be doing a series of these instruction course of an hour or so on various topics which people want to know. To introduce Dr. Jenin, she is an eminent surgeon in Mumbai, director of Raghu Super Speciality Eye Hospital. She has an experience of more than 20 years in cornea, cataract, and refractive surgery. She has a keen academic research, and I always look forward to her video presentations and talks because she puts her heart and skill into it and breaks it down so that people can understand. So over to you, Jenin. Looking forward. We are all just students here, happily and eagerly waiting for your talk, and then we'll have the question answers at the end of the session.
Thank you, Parul, for such a kind introduction that you've given me. So, decoding corneal topography today. So, we all know where the word topography comes from. It is the study of the surface of the earth in the form of color-coded maps. The same concept was now used over the cornea to study the surfaces of the cornea, which was in a color-coded maps as well. Now, there has been a paradigm shift, which we have seen in the way the topographers have been used to measure the anterior surface on the cornea in general. Initially, we started with the Placido disc system, which used concentric rings, and the reflections from the cornea were analyzed by a computer-based analysis system. And what we got was okay, the thing's not shifting. Is the slide?
They were not moving. Just come out of the slideshow mode and do it again.
No, I've got nothing's happening. It's not even escaping. 1 second.
Has it got stuck there?
Okay, no. I think it's okay. So, you have it in the form of a two-dimensional color display where the flatter colors are shown in the blue and your steeper corneas are shown in reds and oranges. So with this, what it gave us was, it gave us a two-dimensional picture. Now, when we treated the refractive errors with these maps, we had bang-on results, because of which there was a sudden surge in the refractive surgeries which were seen. So when we looked at the predictability and the favorable outcomes, Placido did very well. They definitely have a stand today also when we are looking at refractive surgery, because all our anterior surface treatments or our topo-guided treatments, or when we want to do specific surface treatments for keratoconus, the Placido disc definitely has a role to play today. However, it had its limitations. The limitations was it measured only the anterior surface of the cornea. Also, it missed early keratoconus. They misdiagnosed normal corneas as keratoconus. We had no data whatsoever about the posterior cornea. This being a reference-based system, so the same corneal shape gave us multiple curvatural maps. Having said this, what happened was, even though we had a perfect surgery, we had a perfect pre-op evaluation, we had all our parameters in place, we saw a sudden surge of ectasia happening in these patients. Though there must have been multiple reasons for the sudden surge of ectasias, but it definitely brought to light that there was something which was possibly missing. And what we realized is that it became a nightmare for all the surgeons. And what came to light was that the changes in the posterior corneal curvature are critical and often the first indicator for a future corneal disease. Once this came to light, necessity then became the mother of invention, and we came up to do keratospeaking with a lot of newer devices. So what the newer devices did, it offered us more information, different information than the previous keratoscopes gave us, different information than that was previously available to us. And it also helped us look beyond the anterior surface. The first such device was an op scan. So what the op scan was doing is it was a two uh, scanning slit system where it scanned the cornea for 180 degrees. Now the data over here, the posterior cornea was an extrapolated data. It did not truly measure the cornea, the posterior cornea. But what it did give us is it gave us the corneas which were at risk and possibly at a risk of developing ectasia. After this, we came to the Pentacam. The OpScan is not available now, though it gave us very good results. And now it's only available as an OPD scan. Then we had the Schemplug images system in which you had the Galili, you had the Pentacam, and you had the Cirrus. Now, the Galili is a mix of your Placido disc as well as two rotating Schemplug images and Schemplug cameras, whereas your Pentacam is one fixed camera and one rotating camera which takes the images from 0 to 180 degrees. And then we had the anterior segment OCT, which measured the anterior surfaces and the posterior surface. So for me today, the future of probably the devices would be an OCT with a Placido disc, because definitely a Placido disc has a role to play and OCT has a lot of future in it. However, coming to the Schemplug images, what they did was they differentiated the corneal reading from basic curvature-based system to an elevation-based system. The advantage of this was that, like I had said, the refractive properties of the patients were completely treated even via Placido. But it definitely helped us detect the corneas at risk, which gave us structural integrity of the patient. So in refractive surgery, the posterior cornea has no role to play, and hence we could get perfect results even with our Placido. But when we had to detect a normal cornea from an abnormal cornea or a cornea at risk, that's when the elevation-based data or the elevation-based machines play a role, because they detect the posterior cornea. What's more important in this system is that there is a fixed camera which has a blue light which is sent into the eye at 400 some nanometers, and there is a rotating Schemplug image which takes high resolution images. There is an elevation based analysis and a capture of more than 1 lakh points of the cornea, and your posterior cornea is analyzed. These are the true measurements of the cornea that happens through a projection based system. The principle it works on is that at every single point on the cornea, there should be an intersection of the image plane, the lens plane, and the objective plane. And once this intersection happens, it goes through a computer-based software and an analysis is made and a topographic graph is given. Now, this is very important because it helps us detect early keratoconus. It is accurate. It does not depend on the tear film abnormalities or the contact lens wear. It gives us the true shape of the cornea. It does not depend on the orientation of the axis or the position. Now, also, we had initially curvatural maps. Now, what happens is with our elevation data that is collected, which are the true measurements, a curvatural map is got. So this now becomes a true curvatural map for that particular cornea. What the Schemplug imaging does, it measures the various surfaces from the anterior corneal surface, the posterior corneal surface, the anterior chamber depth, the anterior lens surface, and the posterior lens surface. So coming to the various applications which there can be in ophthalmology, they would be the refractive surgeries and patients who are rejects for refractive surgeries with ICLs and toric ICL in cataract and glaucoma. Okay, so the elevation maps will help us derive an anterior sagittal curvature map, an elevation of the front surface, an individual elevation of the back surface or the posterior float of the cornea, and the difference between the anterior and the posterior surface, which would be your true measured corneal thickness of that cornea. So this is how a basic 4-map refractive looks like, which gives us a combination of numerical and statistics and numerical data and the topographic data. So this is studied in forms of first the demographics of the patient, which gives us the name, age, and all the details. It gives us details about the front surface of the cornea. In the details about the front surface, you have the K1, which is the flat axis, K2, which is the steep axis, Km, which is the mean, and an astigmatic number, which is there between the steep and the flat axis. Your corneal back surface will always be a negative number because it will act as a concave lens. Now, when we come to the pupil parameters, the black dotted lines which we see on this graph is the border of the pupil. The black plus sign that we see is the center of the pupil. So it gives us the pupil center and the thickness at the pupil center. The pachymetry apex. So pachymetry apex would be the center of the cornea and the thickness at the center of the cornea. It will give you the thinnest location and the thickness of the thinnest location of the cornea, along with the X and the Y coordinates. So now understanding what are these X and the Y coordinates. So normally in a normal cornea, your thinnest point of the cornea would be at the pachymetry apex, which could be at which could coincide with the pupillary center. Whenever there is thinning of the cornea, what could happen is there could be a displacement of the thinnest point of the cornea. Now, whether the displacement is in the horizontal axis, it will be the X coordinate, and if it is in the vertical axis, it will be the Y coordinate. When you have signs like the plus and the minus, it is in reference to the pachymetry apex. So when the displacement is upwards from the pachymetric apex, it will be in a positive sign, and when it is in the downward direction, it will be in a negative sign. Now we come to the anterior chamber details. Now in the pachymetry,
can I pause here?
Yeah.
So what happens to the left and the right in the x-axis? Will it be different for the left eye and the right eye?
Yeah. So this is the corneal map only for the right eye. Like this, we are displaying only the right eye, and these are the parameters of the right eye. So when we take the details of the left eye, it will be the details of the left eye, and we then compare the parameters of the left eye to the right eye.
No. I'm talking of the minus and the plus signs. Will it differ for the left and the right eye?
No. So the minus and the plus signs are not in the left. There will be a minus and the plus sign in both the eyes. So what happens is you have a pachymetric apex, which is your center of the cornea. Now, suppose you have a displacement of your thinnest point, which is say upwards. Okay. So when it is upwards, it will give you an X coordinate, which will show, it will give you the Y coordinate in a plus sign. But if you have a displacement, say towards the right side, or say nasally rather than right and left, let's say if there is a nasal displacement, it will give you a X coordinate change. But if you have a displacement which is say nasal and inferior, right, that means you're having an X coordinate change which is inferior. It will give you a minus.
Okay.
You want me to repeat the whole concept again?
No, I got that. Yep.
Okay. So when we are looking at the anterior chamber, so I have a couple of examples in the Pentacam itself where we could discuss the plus and the minuses again. So then we have the anterior chamber depth, and in the Pentacam, you have to adjust it whether it is external or whether it is internal. Now, in this particular case, it is mentioned internal. For all your toric ICLs and your basic ICLs, the depth of the internal anterior chamber depth, and your cutoff value is 2.8. Okay, so once we have done this, we come to the anterior curvatural map of the patient. Now, when we look at the anterior curvatural map, what it shows us is, it shows us the various keratometric readings that are taken over the 8 millimeters area at every point of the cornea. So when we have areas which are flat, it will be depicted in a blue color, and areas which are steeper will be shown in red and oranges. Again, you have the center of the cornea, which is your reference point. So any area which is steepening, you will see it in a red zone with asymmetry coming in. We'll look into the examples, but this is how your sagittal map looks, the normal shape of which would be like a symmetrical boat type. Coming to the pachymetry map, a normal pachymetry map will again give us individually measured pachymetry at each and every point in the 8 millimeter zone. The normal shape will be concentric, where you would have your thinnest point coinciding with the pupillary, with the apex, the pachymetry apex. Any displacement of your thinnest point from the pachymetry apex should raise an area of suspicion. Whenever you have corneas which are thick, will be depicted in the blue color. Your thinner areas or your thinning part of the cornea will be depicted in the red color. Coming to the elevation based, which is the parameter of the Pentacam, and understanding what elevation based system is.
Jenin,
So what
Jenin, 1 second. If you want to explain, just can you use the cursor to show the thinnest point and other areas and elevation? Yeah, perfect.
Yeah.
Just use that while you're talking.
Okay, so this is the center and this is the thinnest point, but basically we just want to show the concentric shape of the cornea, of the pachymetry map here. Now, when we're looking at the elevation data, so what does the elevation data do is, so the concept of the elevation comes from the fact is, let's say every cornea is different from each other. So when the Pentacam measures the points on the cornea, it forms a reference surface, which could be probably in the form of a sphere, which best fits that particular cornea. And that will be called as the best fit sphere. So if the reference surface will be in the form of a toric ellipsoid, it will be called as a best fit toric ellipsoid. Now, any points on the cornea which is above your best fit sphere will be denoted in positive. Can you see the cursor over those things? Shit. Will be denoted in positives like this. Okay. Now, any point that is below your best fit sphere will be denoted in negatives like this. So this is basically the concept of an elevation map, and the elevation map is formed for the superior, for the anterior as well as the posterior cornea separately. So I will come to the examples later. So we'll just finish off what we have to see in the maps first. Now, taking this further, once we have the map, if we see dotted areas like this in the periphery of the map, what does it indicate is that the measured points are not done well, and probably some amount of data has been extrapolated. So when that happens, you want to expand it into the 9 millimeter zone. If the extrapolated points disappear, it means that the data points captured are well. And this map is usable for all your further refractive purposes that you need to go ahead with. So coming to, again, these are the extrapolated data, and this map would probably not something you want to use because over the 9 mm zone, the extrapolated dots are still present.
So, what is the area which is allowed per se, that this much amount would be used, and I would go with this map, versus okay, now this area is extrapolated, let's say around 10% or 20% or 30%. What is the cutoff thing for the extrapolated data?
No, so the minute you have extrapolated data first, it's always better to retake the map because you will not have any percentage. Like, okay, 10% of this map is extrapolated. It will not be that because you don't know which data has been extrapolated and analyzed by the computer in which way. All it tells us is that the analysis done is some amount of extrapolation is done and it is not a true measure that has been taken. So if we have a lot of extrapolation, you will have areas which will say that the maps taken are not okay and we need to repeat the scan. If
Can
we
I
do
can
not,
I can I add something, Abhijit? What happens is the QS, the first map which is shown, na, the quality strength, isn't it, Jenin?
no, so we'll come
QS.
to that ahead. We are coming to
Okay.
all this ahead.
Okay. So let's not interrupt, Abhijit. We'll ask the questions a little later because
Sure,
I
No, we
sure.
thought
could
that.
ask it at that point as well. But
Okay.
what you're saying, I'm just coming to that a little later. You're right. We'll come to it later.
The how if the scan has been taken properly or not, the QS value.
Yeah.
Okay.
Okay. So if your scan is not good enough to be taken into consideration, the computer itself or the machine itself will tell you that it needs to be redone. So now we come to, so this is the extrapolated, and such a map will then definitely not have to be taken into consideration. So this is exactly how your Pentacam map looks, and this is how you want to do the reading step by step, like just what Dr. Parul said was, the QS will tell you that it's okay. It's okay to take this map as an acceptable map because all the data points have been covered and this map is good to go. So here you are not dealing with any extrapolated data
Sorry.
in this particular case. The next thing you want to look at is the K-max. Now the K-max is very important because this is one of these things which will help you decide whether you want to go ahead with a blade surgery or you want to go ahead with a femtosecond surgery. Your cutoff value is 47. Anything beyond 47 should be suspicious to us. And anything beyond 47 should not be really put in through a blade. So the fear factors are like if you have a very flat cornea, you're scared of having a free flap. And if you have a very steep cornea, you have very high chances of having buttonholing. So in that particular case, you want to have a K-max, which would be good enough to go ahead with a microkeratome. And if it looks not in a dangerous zone, then femtosecond is a better choice to make. The next step you want to look at is your thinnest location. Your thinnest location and the thickness that is present at the thinnest location and its Y coordinate. The Y coordinate because most of the keratoconus or your ectatic corneas usually displace inferiorly. Now, in this particular case, if you realize there is a plus to the 0.76. The plus tells us that the displacement is there above the reference point in the vertical direction. Okay. So this particular map will tell us that it is a cutoff of 0.5 is acceptable, but anything between 0.5 to 1 should give you the rise of a suspicion, and anything more than 1 should definitely be considered as abnormal. So here, if you have a plus 0.76, it's rising you're raising your eyebrows, but you're seeing a plus that's displaced upwards. Okay, now the next thing you want to look at is the Q value. The Q value is also describing the spherical aberrations or the asphericity of the cornea. When we talk of asphericity of the cornea, it is how away is the cornea from being a perfect sphere. Now, what is your acceptable values is anything between 0 to -1 is acceptable. When you have values above 0, you probably want to be thinking of a patient whose cornea is oblate or possibly undergone a myopic LASIK where the prolate cornea has been made oblate. Anything more than -1 is usually present in a very hyperprolate cornea or an ectatic cornea. So this is your spherical aberration value, and very important value may not be so much in your refractive surgeries, but we'll see the importance of this all the time in our cataract surgeries. You want to see the astigmatism. And the astigmatism on your topography has to correlate with your manifest astigmatism. If there is any discrepancy between your topographic and your manifest astigmatism, it's a sign which you have to keep in mind. The next thing that you want to see is your surface. That is the reference surface that has been used to see your elevation map. That is, you want to see your elevation map in the front surface and the back surface. So here it is the best fit toric ellipsoid. Now, usually a best fit sphere is the best reference surface to use. But when you want to study focal abnormalities or focal points of irregularities, your best fit toric ellipsoid is better because that will highlight focal abnormalities better than a best fit sphere. Now, coming to your pachymetry map, we've already described. So this is what a basic pachymetry would look like. It is nice and concentric. When we are looking at our anterior sagittal and your sagittal, that is your axial sagittal map, you usually will have, like I said, a color coded map and a symmetrical bow tie. Okay. Now let's look at what an anterior map and what you need to study. You want to look at the symmetry of your semi-meridians in the particular plane. You want to know your steep axis and your flat axis. Normally, they should be 90 degrees from each other. And then you want to look whether there is a skewed deviation. We're going to come to that part later. And you want to look at the pattern that is present on the anterior, on your curvature map, because this tells you the shape of the cornea. Like if we look at this particular map, what does this particular map tells us? That we have a hot spot that is present here. Also, when you look at two corresponding points at 5 millimeter difference, what we see is there is a difference in the keratometry reading between your corresponding points. And these things should definitely raise a suspicion for us because this is going to tell us something is going wrong in the inferior zone for the cornea. Next, these are your abnormal shape patterns. So whenever you look at any of these abnormal shape patterns, it should raise an suspicion for the rest of the readings of the cornea. So this is a symmetrical bow tie that we see. This is your symmetrical bow tie, which is a normal pattern. You could also have a symmetrical bow tie with a skewed deviation, which may be normal or abnormal, which you have to look into further readings. But this could also be present. You could have a horizontal symmetrical bow tie. There could be a kissing sign which is present, which shows as inferior steepening, usually seen in pellucid marginal degeneration. We would have a hot spot like this, which would be very, very for your ectatic diseases. You could have areas of inferior steepening in keratoconus, and you look at the inferior superior difference of asymmetry that is present, or you could have a superior steepening that is seen here. So this basically is just an alarming part for you to just get an idea. Are we looking at something normal or are we looking at something abnormal? Once we have finished this, we come to, and when we have anything in the anterior map that shows us an abnormality, you first want to rule out a contact lens switch. You want to rule out misalignment, a large angle kappa. Are we missed out on a dry eye? Or are we missing out on a corneal scar on pathology or a previous corneal surgery? Once we have ruled out all these factors, then we could probably then consider the map. So coming to the next point would be the pachymetry. Like we said, a normal pachymetry is dome shaped, is concentric. But when you have a pachymetry which is dome shaped and you have an inferior displacement of your thinnest point, which is seen here, also the y coordinate, which is definitely more than 0.5 and is way abnormal, this is definitely going to send you alarming signs. So now when we look at the next map, you also want to do the 5 millimeter zone, the difference in the pachymetry in your superior and the inferior region. So when you have a pachymetry difference in two corresponding points, which are more than 30, this should definitely set you to go into an alarm where even if you don't see reds in this map, you may not see any thin point, you may not see the very steep colors or the red. It definitely wants to ring an alarm bell, which tells us that the two corresponding points have got a difference of more than 30 diopters in them. Again, if we look at the y coordinate here, it shows a displacement of minus 1.39. But when you look at the thinnest location in this particular map, it is showing us only minus 0.27. That means there is not so much of a displacement yet when you're looking at it from the point of view probably of pachymetry effect. There is a displacement into the left eye, but the right eye is not showing us a vertical displacement as yet. Now, the very, very important part of refractive surgery is angle kappa. Now, none of the topographers ever measure angle. What they do is they measure the distances, which are then converted, or maybe for the sake of ease is called as an angle. But the difference between a pupillary center and the fixation, the distance is what is measured, and that is called as the angle kappa for convenience. And on your topographer, this x coordinate, that is your displacement, is the angle kappa that you want to look at. So anything more than 0.5 is a red sign for you to go ahead with refractive surgery, for a simple reason that you are not very sure of how the patient will present with glares and halos. You want to also make an adjustment for pupillary offset in this particular patient. This usually would happen in patients who are hyperopes. So coming back to the elevation data, we have discussed the elevation maps. We have discussed the concept of elevation maps. So in the elevation maps, you're not really looking at a design or a pattern or a color, but here the numerics are very, very important. And any elevation on the front surface of more than 12 microns is something you want to take suspiciously, and more than 15 is a definite risk factor and a no. And in the back surface, anything that is more than 15 microns is something you want to take with suspicion, and more than 20 is a definitive no. So this is an example of a patient where you have the thinnest location of the patient, which is seen. So let's read this map step by step. It's good to go. You have a Q value, which is say minus 0.45, which is still good. All your keratometric readings are good enough, and astigmatism of 1.5. You have a pupillary pachymetry and your pupillary apex, which is good. Your thinnest location is also nice and thick enough. It's got a 525, and there is not much of displacement, and you have a good chamber depth over here. But here you see there is an external. That means the depth is calculated from the corneal epithelium and not from the endothelium. But when you look at the anterior sagittal map, what we see is an irregularity in all the semi-meridians. Now, this is something that should raise an alarm in your mind, because this is not normal. Again, we look at there is a displacement of the thinnest point of the cornea. Though the elevation map over here does not show us much of an elevation in terms of our microns, the posterior map is definitely giving us a sign of a plus 20 and a plus 25. So when we look at this 4 map refractive, it's definitely something that you want to be cautious in this particular cornea. So coming to the enhanced reference and the reference surface once again, because this is something that is very, very important, and very important to the Pentacam, to the ectasia disease, and to ruling out your corneas at risk. So again, like we discussed, you have a reference surface, which could be in the form of a Bestwick sphere or a Bestwick toric ellipsoid. A reference surface will be different for each and every cornea. So you have a corneal surface which is like this. Any point on the cornea which is above your reference surface is denoted as plus. Any point below the reference surface is denoted as minus. Now, what happens when we talk of an enhanced Bestwick sphere? Okay, let's get back to this original slide. So when we have this particular slide, what we see is that this part of the cornea, this area of the cornea has been masked by the reference sphere, right? So most of the anomalies or most of the focal abnormalities or thinning or pathologies will occur in the central 3.5 to 4 millimeter zone. So what the enhanced best fit sphere does is it minuses that area of that cornea, that is your central 3 millimeters and 4 millimeters, and it forms a new best fit sphere, which is an enhanced best fit sphere, which will now fit the cornea differently. So what happens in this situation is all your masked points will get more exaggerated, and all your focal abnormalities which probably were masked or were not taken into due consideration will be enhanced with your best fit sphere. So I think this is a very important thing, and I just hope everyone's understood, or do you want me to repeat this part?
I think you can just elaborate one more time and put the cursor there to explain.
Okay, so let's start with this again. When we talk of a best fit sphere, like I said, there will be every point on the cornea will be measured, and it will be measured from the center to the periphery. Now, for that particular cornea, the reference surface will be a reference surface which is best fitting that cornea in the shape of a sphere. So say you have a corneal surface which is like this. The best fit sphere for this corneal surface, say, is in this form or this shape. So there would be some parts of that cornea which would project upwards or which would show as elevations which are above the reference surface. Some points of the cornea which are below the reference surface will be shown as negative values. Now let's say we have a cornea with focal thinning at the center. Now, when we have a focal thinning at the center and we have a best fit sphere, say like this center has been masked. It is not going to show up as an abnormality. So what does an enhanced best fit sphere do? It minuses this area completely. So it does not take into account the central 3 millimeter or the 4 millimeter for forming a reference curve. Now only the mid-periphery points and the peripheral points are taken and a new reference surface is formed. This new reference surface is going to be your enhanced best fit sphere. So what does the enhanced best fit sphere do? It will, so if this abnormality is there, say this part of the cornea is hidden below the best fit sphere. Now when you have an enhanced best fit sphere, this fits the cornea more tighter. So these anomalies are going to get exaggerated in the best fit, in the enhanced best fit sphere. So I think is it a little clearer?
Yeah.
So okay, we'll see it further in examples, and I think that will help us
So
understand this
what
concept.
is the basic application of this thing?
So the basic application of this is, like we say, all the changes will start, say, in the posterior curvature, or if you have patients who are early keratoconus. Now, these patients would probably be missed when we just do a routine sphere fit. So when we do an enhanced best fit sphere, this will get exaggerated. This will get clearer, and you are going to get these elevations more seen in your Pentacam reports or in your topography reports. So let's see some examples, and I think that will probably make it clearer, or else we'll come back to the concept again. So let's say this particular patient. So here what we see in this graph is, so looking at all the numeric readings are fine except for your thinnest location, which is 0.66, something that wants to give you suspicion. Coming to the sagittal curvatural map, in your central 3 millimeter, you know that, okay, this is not exactly 90 degrees to one another. When you're looking at your pachymetry map, more or less is giving you okay. Your anterior elevation map is also giving you okay with none of your values in the zone you are worried about. When you look at your posterior elevation, you have a 15 here, which is just something to be cautious about. Now, when you come to the Bellin-Ambrosio enhanced display, This is your elevation with your best fit sphere. So when you see the elevation with the best fit sphere, what it gives us is elevations of 14, 8 and 10. That's what is your elevation. So when you then would look at just without any of your further readings, this is going to be almost a normal cornea. Now, when you use your enhanced best fit sphere, so there is some focal anomaly that is happening here, which will come out in a more exaggerated form with your enhanced best fit sphere, because this is now going to, it's a new reference sphere that's formed, right, which is negated the 3 millimeter area. So your central anomalies and your central focal irregularities are going to get enhanced in this particular graph, in your particular area. And what this gives us is an enhanced area of 23, 28 and 24. Now, this is something definitely that is showing us that the posterior corneal curvature is not showing us elevations, which is normal, and there are some changes happening in the posterior corneal curvature. Now, when you minus the elevation of the front, that is your best fit sphere, from your enhanced best fit sphere, this is the data you get. And this data is the one that you want to refer to know whether it is normal or not normal. And you get a change of, say, 5 in the anterior surface and 14 in the posterior surface. Now, what this has also done, it has made it very easy proof by telling us that if you see anything in the yellow, it is suspicious. If anything in the red, it is something that you have to be cautious about. Anything in the green is normal and you're good to go. You also have deviations which are seen over here. Now, what these deviations tell us, this is the deviation of the front surface. This is the deviation of the back surface, the deviation of the pachymetry, the deviation of the thinnest point of the pachymetry, and the deviation of the vertical displacement. And this is the total deviation. So when you look at the deviation here, you see 2 of them in yellow. It is something that you are cautious about.
Can we go back on the deviation part again, please?
Okay. So these are the D values, okay, which are also called as the bad D values. So these bad D values are going to be broken up into 5 different parameters. The first parameter is your deviation of the front surface. So it is going to tell you how much is it deviating. If you have a completely normal front surface, it will be shown as a white. If so, all these values in white are normal. Anything which is in the yellow is in the suspicious zone or in the zone of the 2 standard deviations. And anything which is red is dangerous. So when you look at the deviation, this tells us that there is a deviation in the front surface. There is a deviation in the back surface. There is, your pachymetry is normal. Okay, so the pachymetric D is normal. When you look at the thinness, the thickness and the thinness, so the thinnest points in the pachymetries are all normal. And when you look at the displacement of the thinnest point of the pachymetry, even that's normal. So now when you take an average of all these Ds, you get a D value, which is like this. You don't need to remember any numerics over here. Just the color is good enough to know that this is in the suspicious zone. Okay. So we take one more map to just understand this concept a little better. So let's look at this particular map. So I'm not getting into the numerics now because the numerics is very, very simple to understand. So here we see the sagittal curvature is giving us symmetric meridians over here. Our pachymetry is more or less similar, normal. It's not got any abnormality in terms of thickness or in terms of deviation. When we look at the anterior elevation, they are all looking good. Our values are 7733. When we look at the posterior elevation, what we are seeing is a value of 25 and 23. It's raising our bars. Something may be wrong. Now, when we come to the enhanced best fit sphere, what happens when you just look at the normal best fit sphere? It gives us values in the posterior surface of elevation, like say 23 and 25. But when we do the enhanced best fit sphere, that is the central 3 millimeters and the 4 millimeter is eliminated. When a new reference curve is fit onto the cornea, these regions that are there are now going to get even more exaggerated and it's going to show us in a red. And the first map minus the second map is something that is going to give you the final map. And in the final map, so even though all your initial parameters were normal, what the bad D could do is pick up these focal and abnormalities and irregularities and show us a cornea which is at risk, which is not probably fit or should be treated with suspicion before we go ahead for a refractive surgery. So once we see something like this, it's definitely you want to not do the surgery. So let's go back to the map again. Just
So
to see how now.
correct me now. Correct me now if I'm wrong. Now, if I see this and I go to the Bellin Ambrosio thing, does it automatically do the best fit sphere there?
Yeah. It automatically does it. The software does the best.
So I don't have to add that thing out there, right?
No. You don't have to do anything. It's just the concept of how the map comes to you like this. You see it in forms of colors. We don't do any adjustments on the cornea. So it's the basic of how the software has been made for the focal anomalies to be enhanced. It's just an explanation of the software. Machine-wise, we do nothing. We just
now here, if the BAD is giving me a yellow, still
that total D.
Yeah. Now in this slide, if my DF as well as DB are still yellow and my D as well is in yellow, then what do I do?
Okay. So if you have one odd parameter, like you're right now, you're talking about a DB and a DF, they both are yellow. So it's not only the graph, I would say. What you're also going to look at is the age of the patient, the refractive error you want to go ahead and treat, whether the cornea is thick and how thin is the cornea, what is your other residual parameters that you're going to be leaving behind in terms of your residual stromal bed. So say I am treating a patient with this cornea, which is 530. So obviously this cornea is something that I would put for progression and not want to go ahead and treat. But say I am forced to treat this particular cornea, what I would do is I would do a surface for this patient. And probably if I feel that this is not a very great thing, I would also do a C3R for this patient and I would lock up the C3R because now I'm not going to let progression happen. It's also to bring to the point that sometimes your changes could start in the posterior cornea and not yet reach the anterior surface of the cornea. And this will help you pick up the subtle changes which are happening in the posterior cornea, where the patient's vision is still good, patient is not feeling anything, but subclinical changes are happening in the keratoconus. Now, if you miss this in a routine placido-disc topographer, we've gone ahead and lasered it. This is a sure case that will give us an ectasia in future.
What about the progression index? How do you do that?
Yeah, so we will come to that a little later. I will show that in a couple of examples.
Jenin, on this map, there are above also in there is a red and yellow there. So front elevation thickness and the back elevation thickness.
Yeah, so that is what we are discussing, no? That this is the front elevation, okay, which is only 7 over here. Our cutoff value is something which is 12. Okay. Now the back elevation thickness, our cutoff value is something which is 15 to 20. So 16 is something that you are definitely looking at. Now the front elevation, when you're changing it to the enhanced best fit sphere, if you see your 7 has now become 16. So when your focal, the central 3 millimeter zone is removed, your front surface is also showing us some changes. Right? And then when you do a front surface, that is your best fit sphere minus your enhanced best fit sphere, you definitely get a elevated data that is seen in the lower map.
Dr. Jenin, just a question. The value that you were mentioning, -15 and -15 to 20, sorry, plus,
plus.
are for the best fit sphere or for the general, the normal?
No. Yeah, so that's a
without
very
the-
good question. So, when you're looking at the values in the best fit sphere and the best fit toric ellipsoid, right? So the best fit sphere will, so these are values which we look at the best fit sphere for general cornea. Like I told you, for your general screening, you're not wanting to look at best fit toric ellipsoid. Your best fit toric ellipsoid, you want to look at when you want to kind of map the focal changes or the focal thinning of the cornea or the effects of the cone of the cornea. You're then more interested in using your toric ellipsoid. Toric ellipsoid is more localized. Since it is more localized for that cornea, it's going to give you more exaggerated values compared to a best fit sphere. So suppose your one map on a best fit sphere will show you 12, the same map on your ellipsoid maybe will show you a 16. You get my point?
Yeah, yes.
Yeah. So the toric ellipsoid and your best fit sphere will definitely differ in terms of your numeric values, but you want to take a best fit sphere when you're doing a local screening for knowing a patient is a normal cornea or an abnormal. So we are only doing this. Let's understand this to rule out our corneas at risk of an ectasia in the future with our refractive surgery, and you want to rule out a normal cornea from an abnormal or a suspicious cornea. So the points that we are keeping into mind are possibly this is a suspicious cornea, possibly I must look after this cornea, possibly not want to go in for a refractive surgery, or I go in for a refractive surgery with a backup plan of being safe. So if I'm forced, like I said, if this particular cornea I'm forced to do something, I would definitely do it as C3R because I'm seeing very, very strong changes in the posterior cornea. We all know changes start first in the posterior cornea and very slowly they do reach the anterior cornea. By the time it reaches the anterior cornea, the patient is already facing visual complaints.
So in this case,
our main aim would be to intervene before the visual loss happens. Yeah.
So in this case, if we are looking at the back element, it's in yellow. The front element is in red, right?
Which one?
In this same slide.
Which back element? Here, this one.
Yeah.
No, this
and
is
the progression index is like in green. It's like 0.65.
Where?
Are we on the same slide? Yes.
Oh, yeah. Okay, you're talking of the numeric. Okay.
Yeah.
So
the front is in red. Probably this may be an epithelial thing, which is a bump here, versus
this is the back surface. This is the back surface. This is the posterior.
Which one? The red.
Yeah. The middle red is the posterior float. These are the changes in the posterior float. This is the enhanced best fit sphere of the posterior float.
Can I ask one question?
Yeah.
So you mentioned that elevation of back surface more than 15 microns is suspicious. Now, is this elevation for the best fit or the enhanced minus the central?
Okay. Yeah. So it is for the best fit sphere.
Okay.
Now, when we are looking at the enhanced best fit sphere, the only reason why we are using an enhanced best fit sphere is to exaggerate anomalies or areas of the cornea which have probably been missed or have been taken more lightly under the best fit sphere. So when you are looking at a enhanced best fit sphere, you're not looking at a particular value. You're probably just looking at whether that area is getting exaggerated or not. Then whether it is exaggerated by a 30 or a 25 or a 27, it doesn't matter.
Okay.
When we are looking at the main 4-quadrant map, that's when you want to know whether the elevation is there in the front surface and the back surface. The enhanced best fit sphere, that is what we call as the Berlin-Ambrose should display, is only used to tell us that this is an ectatic cornea and a dangerous cornea, which possibly would have been missed by your other topographer.
Okay. So the reference is the basic elevation.
Yeah, it is not in your enhanced elevation. Your enhanced elevation, any which ways, is going to get, see, when you're worried about a 15,
Yeah.
Your enhance is
Correct.
definitely going to be more
Yes.
than 15.
Yeah.
Right.
Dr. Jenin, I just want to know what does this signify, CTSP and PTI?
Where are we, sir? This PTI, no?
PTI and the above graph, both of them, what
Yeah,
is their
so we'll
significance?
just come to that in a little bit. So when we move ahead, I have it in my next slide. I'll just come to that as well.
All right.
Okay. So I think this is clear now.
Yeah.
Okay.
Yeah.
Okay, so just to enumerate how we want to look at the areas, you want to look at whether it's okay, you want to look at the Q value for the asphericity, you want to look at the thinnest location, the K-max, you want to look at the corneal thickness, you want to look at the shape of the anterior sagittal, any abnormalities, the corresponding point, your elevation numeric, and your back surface elevation. Once we have come to this, we've also understood the bad display, which is very pathognomic for the ectasia and which is Pentacam. Now coming to what is a corneal thickness spatial profile. So this works on the principle that there is a gradient of thickness increase from the center of the cornea to the periphery. That is a gradient. So there is a gradient which will be the cornea will increase in a particular format from your center to the periphery. This is plotted in the black line. Now, when you have your red line that goes across like this and follows the route of the black lines, it is considered as absolutely normal. However, if it does leave the black lines before the 6 millimeter mark, this is considered abnormal. So what does this tell us? This tells us that the gradient of increase of thickness from the center to the periphery has lost its normal path. So let's assume a case of keratoconus where you have a focal thinning. That gradient to which it will increase towards the periphery is not going to be same to the normal cornea, right? So that's when this red line is going to be off the 6 millimeter zone, and that tells us that this cornea is not in its normal thickness. So this map is something that I call as the pachymetry progression map, which could also be called as the corneal thickness spatial profile or your percentage thickness index. This is just a basic way of one is turned into a percentage and one is this, but the basic idea remains. It is the progression of your thickness from the center to the periphery. If it follows the two graded lines, you're good. If it loses the path before the 6 millimeter zone, that's the cornea you want to be cautious of. So somebody asked me that question. Are we clear on this?
Yeah.
Okay. So another very, very important parameter when you're also looking at this factor is your average. Now, any average which is more than 1.1 is a red flag sign. So even if you have your graphs do follow the path, but your average is more than 1.1, you have to be cautious. So that's the numerical value which you definitely want to remember.
Where is the 1.1, Jenin?
Yeah. Where the 2.6 is, it's flagged here.
The average progression index.
Yeah. This average is something that's very, very important.
So that the machine is anyways highlighting it.
Yeah, if it is normal, it will be white. If it is abnormal, like it's suspicious yellow. If it is abnormal, it gives you the red.
But if it is
Okay,
a
so this
progression
is the
index, is it with consecutive imaging or is it with the first image?
No, the progression index will be for every image. No? For every image, it will give you a progression
So
index.
we are talking of the progression from center to periphery.
Center to periphery for every image. It's the
For every image. Okay.
Madam,
so
madam, one question. The three lines, the central one, we would take as the base, and the upper is the upper limit and the lower is the lower limit. Is it something like that?
So it is basically 2 standard deviations on either side.
Okay.
Okay. Can I request, there is some Rupali Panse who's logged in. I think the child is on the screen doing a doodle. So whoever is logged in as Rupali, please take care. Okay, Jenin, go ahead.
Okay. So let's look at this particular map. Now, okay, this is the map that Dr. Abhijit had asked the question in the beginning, and I just have put it in for sake of understanding an abnormal corneal pathology. So this is the map, which is now again definitely when you look at it, you know it's abnormal because you're having your semi-meridians not symmetrical to each other. The other thing, what you're seeing in this particular map is if you look at the thinnest location of the cornea, the thinnest location of the cornea is way towards one side. Another point what we also want to notice is if you look at the dotted lines, the black dotted lines, they are really huge, which also gives you an indication that possibly this map has been taken in a dilated pupil. Now, when we look at the coordinates of this particular map here, it tells us that the x coordinate is shifted completely by 2.4. That is, your horizontal axis is showing the thickness and it is in the upward direction. Now, when you look at the rest of the patterns, it is not showing us any of our red flag signs. Also, incidentally, when we look at the Berlin embryo, the Berlin embryo difference is giving us a completely normal difference in the green. So it's going green, it's normal. But what I want to also bring to light is if you look at the pachymetric progression, it is completely meeting its shape. So possibly this could be a thinning or this could be a scar at the corneal periphery, but the thickness from the center to the periphery is completely lost, and you also get the loss in the pachymetric progression map like this. Okay, well, this has got nothing to do, but this is just to highlight the points that we were making. All right. Another very, very important factor is an inter-eye corneal reading. That means you definitely want to compare the two corneas, and you have parameters that the two corneas should not be more in the anterior keratometric more than 0.3 diopters, the posterior keratometric more than 0.1. Your thinnest pachymetry should not be more than 12 microns different from the two eyes. Front elevation at the thinnest point not more than 2, and your back elevation not more than 5. Now, why is this important? Because if you see a difference between your right and your left eye, you may probably want to go on a back step to re-evaluate the whole case. And any of these parameters then becomes a risk factor and has to be taken into consideration. So these are your risk factors. We have discussed most of them. Let's just go through the thinnest location, your y coordinate displacement, the Q values, your shapes on the anterior sagittal curvature, your elevation map of 12 and 15, the shape on the cornea and the thickness map on the pachymetry, and your thickness profile that is present. So the rejection criteria will be 1 high risk criteria or 2 moderate risk criteria is a definite rejection for a refractive surgery for that patient. 1 moderate risk criteria, you could go ahead with a surface treatment for that patient. So let's look at some clinical examples. So probably we'll understand this thing better. Again, when we look at the numerics in this particular patient, all the numerics are normal except for the Kmax is 51. When we look at the curvatural map, it's looking normal. Your pachymetry is looking normal. You do not have elevations on the front surface, no elevations on the back surface. When we look at the Berlin embryo, your Berlin embryo back surface, probably little suspicion, but when we are looking at the difference between the two, it's giving us a clear zone. Again, looking at the pachymetry progression, it's giving us a clear zone. What is the only criteria we have is, we have a criteria of 51.2, which is an high risk criteria. And like I was telling Dr. Parul, an average of more than 1.31. An average of more than 1.1 is a risk factor, even if your maps look normal. So this particular patient would, in spite of normal maps, just with a 51 and an average like this, would be kept on a hold for the surgery. So this is the other eye of the patient that you want to compare. And this is the same findings that we see in the other eye as well. And we do an inter-eye corneal asymmetric score for this patient. And this patient could be kept as a suspicious case for refractive surgery. Looking at another case like this is a patient who again on your anterior sagittal is giving you asymmetric Myers. If you look at her pachymetry, it's a little way off. You look at her posterior elevations, you don't see too much of change. Anterior elevations are looking normal. When we look at the Bellin-Ambrosio display, it's giving us an enhanced posterior surface and some changes, which is some changes of 12 and 13, which is still something you can be cautious of. And probably you could do this patient in a and not use LASIK for this patient because the rest of your parameters are coming normal. But when you look at the other eye, your decision for this patient changes because the other eye Berlin-Ambrosio is definitely giving us a red here. It's giving us an extreme elevation here. And when a patient shows changes in the posterior surface of both the eyes, this is a patient who can be at risk. So this patient should then be put on a progression follow-up. And this is what we were talking about, where the parameters, so individual areas of the cornea are broken up and the progression is analyzed. So what it does is A stands for the anterior surface, the B stands for the posterior surface, the C stands for the thickness, that is your thinnest point thickness, and D stands for the visual acuity. Depending on this, you put in the values. When we call the patient 3 months later, 6 months later, these values can be put in again, and this patient can now be looked for a progression, whether the keratoconus changes are occurring in this patient or the patient is maintaining stability over the years. Now, there is another map, and I don't want to get that in here, but since we're just talking on this, that other map also shows us whether you want to do it to the basic clinical. So it's a green flag and a red flag. Red flag, if it is an advanced keratoconus, you compare it to the red flag. And if it is a subclinical, you compare it to the green flag or the normal population. And then you assess the progression and how it's happening. And then you can decide in future what you want to do with this particular cornea. Now, this is another patient where the patient's rest of the parameters looks good. This is the anterior sagittal map that we see, and all the numerics are parallel. Now, this patient has a thickness of 525, and the deviation is also not much. It was a minus 0.67 with a very small error of around 2.25 with a cylinder of 1.25. When we did in Berlin-Ambrosio, both eyes showed us the changes in the posterior cornea. So LASIK for this patient was completely out of question. But since the patient was so desperate to have a refractive error treated, we went ahead and done we kept him on a progression analysis and a progression mapping to see how he progresses over the years because he had no idea he had a keratoconus ever. And what we did for this patient is we did a topo-guided PRK with a C3R. And I'm not getting into the details of the treatment, but the irregularities on the cornea were corrected. His refractive error was addressed to, and the C3R was done because we had a good thickness of the pachymetry and not too much of displacement of the apex. So coming to another example in this particular case, where again, everything is looking on the normal. And okay, so this one case where we have a little bit elevation in the back surface, we have decided that the thickness of the patient is 3.09. The rest of the eye is normal. But what have we missed is his thinnest location is 449. The pachymetry apex is 451. Now, this patient is a normal thin-eyed cornea. But because he's a 450 pachymetry, we've not done anything, but has not every thin eye and not every elevation on the back surface will then be a keratoconus. So this is something. So if you have one odd displayed like this, it's something you want to kind of look into and not go in for a refractive surgery just because you see a green and a thin cornea. You have to value the cutoff values as
See, and this is the beauty of bad. No, in the previous map, Jenin, just go back. It already says only one is red, and that's the deviation of thickness. So that's a thin cornea. So only one box, that particular one is red, and rest is okay.
Just because
basically, bad is mainly for just people to understand, and interpretation is easier.
Yeah, and for people to say the cornea at risk, and it's just the color, so it's very idiot proof. A green, a red, a yellow, and it becomes easier. Okay, so this is the patient on this. So another very, very important use, and I've used another topographer here just to bring up the use of topography, is in the use of intacts. Intacts are used for keratoconic eyes, and intacts are, all of you all know, are intracorneal ring segments. So what you need to do in these cases is first look at the posterior float and the pachymetry float of the patient. I'm not going into the details of how we do an intact, but these are the two floats you want to look into. The next most important thing you want to know whether your cone is a centered cone or a decentered cone. So for a centered cone, when in your posterior float, when 50% of the cone lies within the 3 millimeter, it is a centered cone. When more than 50% lies outside the 3 millimeter, it is a decentered cone. Now, this helps you decide whether you want to go ahead and use symmetrical ICRs or you want to use asymmetrical ICRs. Asymmetrical ICRs, like this particular case, is a case of a post-LASIK ectasia. This is something that we all have seen. And you would probably want to use an ICR in the inferior segment to lift the cone upwards, because in your 3 millimeter zone, what we see is a disparity of and an irregularity in the surface. So probably by lifting the cone, you're going to make the cone more regularized, and then go ahead and cross-link this particular patient. Okay, so before we start role of topography in cataract, do we have any questions for refractive?
There is one question, Jenin, do we check tangential curvature map for LASIK or axial curvature map is sufficient?
For what?
For LASIK, for looking at cornea.
Yeah, so for a basic LASIK, when you want to look at a normal patient who's walked into your OPD and you want to see if he's fit for a LASIK, just the basic axial sagittal curvature map is good enough. You do not want to go, you do not need a tangential map. You need tangential maps when you're dealing with irregular astigmatisms, when you're dealing with ectatic corneas, when you're dealing with focal anomalies, and you want to exaggerate or know exactly more about that particular zone. That's when your tangential map is more important for us. So basic normal corneas, just a basic sagittal curvature would be good enough. So can we move ahead to the role of topography in cataract surgery?
Yeah.
Okay. So I think today what's happening with cataract surgery is that the patient walks into the OPD, we see him on a slit lamp for probably less than 5 minutes. The patient is, an optical biometry is done, maybe on that same day or another day, and patient is posted for cataract surgery. Now, what in the whole process is missed is that the same person is not doing the optical biometry and seeing the slit lamp. So what we are also missing out is the mindset shift that patients have. Patients want to see better than they developed cataract. Their level of expectations are extremely high, especially with cataract surgery. And with the total new advanced technology IOLs that are there, it becomes extremely difficult when they have made a choice of these IOLs and they do not get their optimum result. That's when it becomes extremely disheartening for the patient.
Ma'am, may we request to mute the person? I think there is a lot of disturbance in the background.
Parul, can you mute everybody else if that's okay?
Go ahead, Jen.
So when we have these advanced technology IOLs and we have a patient choose the advanced technology IOLs and you have a perfect surgery and the patient walks in and says, I'm not happy, and you can't get your reason why, it can become extremely disheartening at both ends, at the surgeon end and the patient end. So today, cataract surgery cannot be treated as cataract surgery, but of course, it's a cataract refractive surgery and needs to be done with the same precision as a corneal based surgery. And you want to look into different parameters on a topographer into the patient for a cataract surgery. The reason being that not all the causes of vision blur is a cataract. You have a large number of corneal causes for a patient's visual blur. And these could not be picked up on your slit lamp biomicroscopy or your optical biomicroscopy and can only be picked up by a topography. So when we are looking at pellucid marginal degeneration, you're looking at early keratoconus, you're looking at a corneal scar and a pterygium. But most important, a Shalman nodular degeneration. For me, there are two very, very important things which even basic normal population, the age, the population and the geriatric population would definitely be suffering from are dry eyes and aberrations. Now, why is aberration so important is because we have lived an era where the refractive surgery has gone to a boom. We are now going to be treating a lot of cataracts in patients who have had previous refractive surgery. Not all patients know what type of refractive surgeries they've had, and many a times they may not even tell us in our history taking that, oh, we've done a refractive surgery. So your topography is one of the best tools that can pick up all the data of the cornea and give it to you, even if the history, if that particular is missing. So what are you looking in a topography for? You're looking for IOL power calculation. The next very most important thing is deciding what type of IOL you want to put for the patient and improving the basic quality of the vision of the patient. So you want to look in a topography in 4 major steps. One, you want to look at the irregular astigmatism. Now, the irregular astigmatism, whether a patient has regular or irregular astigmatism, the one way, see, because with a cataract, you cannot really rely on your refraction as much because your refraction is anyway going to be masked. So to then talk about a regular or irregular astigmatism on your refraction is going to be really difficult. So in this particular case, you have higher order aberrations. So when you have higher order aberrations more than 0.3, it is an indication that the patient has higher order aberrations present in the cornea and you're dealing with corneal irregularities. You want to look at the abnormal shapes in the cornea, which we discussed in the maps before. You want to look at the corneal spherical aberrations also, which are part of it we discussed. We look at it with clinical examples. And you want to look at the corneal cylinder in the patient. Now, this is really important when you're going to be deciding for your toric IOLs, more so in patients who have undergone refractive surgery or in a patient who has corneal irregularities. Now, sometimes there are lots of cases where we do not know whether we should do a toric, not do a toric. Routine torics are quite simple, quite doable, but these are those midline cases or your borderline cases where you do not know whether it's a yes or a no. So we look at a few points in this for those as well. So when you want to focus on your corneal irregularities, you want to focus on aberrations. I'm just repeating this, whether the patient has had a previous refractive surgery and your total corneal refractive power that has to be known in the patient. So this is an holidays report. Now, the first column will give you the basic topography of the patient. So you just can look at what the topography and your segments that you're seeing. It gives you the basic pachymetry, so you know whether you are dealing with an ectatic cornea or a post-LASIK cornea. And it gives you the elevations of the front and the back surface. To me, what is more important once I glance through this are these numerics. Because when I'm looking at corneal irregularity, the first thing that I'm going to look at is the higher order aberration. Any cutoff which is more than 0.3 is not a candidate for multifocal IOL because the patient's aberrations are going to cause a blur enough and he's going to be an unhappy multifocal patient. So any patient with a higher order aberration of more than 0.3 could be your cutoff and not a multifocal or a trifocal patient. The spherical aberrations, like we discussed, in the holiday, he has added the Zernicase 4, 6, 8, and 0. So it's given you a total spherical aberration of that particular patient. Normally, we look at only the 4-0, but here he's looked at the total, though the values remain the same. Now, when we're looking at spherical aberration, the cornea, when it is at a perfect spherical aberration of, say, 0, there will be a blur, whether he is positive or negative, to the amount of the spherical aberration that is there. So if there has to be some kind of a spherical aberration for the patient, it's better that we give a patient a little negative spherical aberration, and this helps the patient see the near. So many a times we have seen patients who are 6'6", post a monofocal lens, also have a very good near. The reason is that that particular patient has a negative spherical aberration, which is helping him see the near. Another very important factor is your EKR values of the K1 and K2. Now, these values are extremely good, like I said, for all your corneal pathologies, whether it is a post-refractive surgery, whether it is a scar, whether you're dealing with any corneal irregularity. What the EKR value does, it incorporates the posterior corneal value into the anterior corneal curvature as well, and then gives you a value, which is your EKR K1, which is your flat, and EKR K2, which is your steep, and the mean EKR. Now, your mean EKR is not the EKR of K1 plus K2. We'll come to what that is, and the astigmatism in the EKR. Now, a very important factor, if a patient has not given you the history that he's had a previous refractive surgery, a ratio which is less than of the back and the front surface, which is less than 80, is an indication that the patient has undergone a refractive surgery. So these are just the values that are very, very important. And when we're looking at another map, that is the map onto the extreme right, this will tell us what is the estimated refractive K-metry of the patient before the refractive surgery. This is important and may be used when we want to do IOL calculations with the double K method. What is the tentative refractive change or the amount of refractive error that he went in for surgery with? That would be a 1.7. Now, another is the chord mu length, that is the distance which is measured over here. And again, this is a very important criteria when you want to choose patients for multifocal. And if your quality of the scan is okay or not is what is seen. So these are the important criteria you want to look at in a patient. This is another map that the Holiday has given, where he has given the EKR values, that is the values of the compensated posterior cornea over a pupil range from 1 to 7. But the one that is mostly used will be your 4.5, because even in a mesopic condition, this would be the diameter that your pupil dilates to, and these would be the EKR values you want to look into. Any EKR value between the mean and your K more than 0.5 should give you an error where you want to counsel the patient for maybe some changes that could occur post-cataract surgery. This is an histogram of the value distribution that you see over the 5 millimeter, the 4.5 millimeter. If you choose a 2 millimeter, you will get the distribution over a 2 millimeter. If you choose a 3 millimeter, you will get it over 3 millimeter. So depending on your patient's pupil size, you could choose these values and get the histogram display that is seen. What this tells us is if you have a binodal peak like this, that means the patient is not having a point focus. So, okay, we'll come to the meanings maybe a little later when I'm going to show the examples. So when are we going to use a total corneal refractive power to determine the IOL, whether we want to use a toric IOL for that particular case, or whether we want to not use the toric IOL, and if we are using the toric IOL, what is the axis orientation? Because many a times you will have a patient which has different axes. So when do you want to orient the axis? Because we know that for 30 degrees change in the axis, you get your complete refraction back. And every degree change, every 10 degree change you are going to have, there is going to be a repercussion on your toric IOL result. So this is another map, and this is a patient. So the way we are going to read the map, to just make that easier to understand, The first step is read the higher order aberration in the patient. You want to read the spherical aberrations in the patient and the astigmatism. So now this particular patient has everything in normal. If you look at the histogram, you have a nice single tall peak. You do not have too much of astigmatism in this patient. And if you look at the EKR values in this patient are all normal with a 0.5 diopter difference, and the cord mu length for this particular patient was also less than 0.5. So this particular patient is a very good candidate for a multifocal IOL. Now, this is a case where the patient has undergone myopic refractive surgery, which you can see over your graphs. So looking at your spherical aberrations and your higher order aberrations first, they are not much, but your spherical aberrations are way off and you have a 1.07. You want to bring the patient as close to minus as possible. So you are going to use an aspheric IOL with the highest negative spherical aberration that is available. It's available in 0, minus 0.17 and minus 0.27. So the best to use in this patient would be a minus 0.27. So again, this is another display of a patient where you have an histogram, which is seen, which is binodal like this. So when you have a binodal peak like this, it means that there are two areas where you are having maximum amount of haze with a plateau in the middle. So when you have a case like this, you want to progress very cautiously with multifocals because they may not do very well with multifocals. This is the power distribution map that is seen in a patient. Now, this is another case where you see a patient with keratoconus. You see the astigmatism is only 0.3. The spherical aberrations are minus 0.5, and you have the RMS or the higher order aberrations, which are still okay. Now, this particular patient has a peak which is like this. So you will go ahead and just do a traditional spherical aberration, a spherical IOL for this patient, not putting in a toric. Now let's go back over here to understand these values. So you have values of the anterior corneal curvature, which is telling us that there is no toricity in this patient. But when you look at the total corneal refractive power in this, it is telling us that there is an astigmatism of 1.1. And when we look at the difference between the two, it is giving us a difference of 23.5 degrees. So if I have to consider, now this particular patient I am not going to treat because for toric IOL, one, my graph gave me a binodal peak. Second, my anterior surface is only showing me 0.2. With a 1.1 on the posterior surface is something I definitely want to be cautious. Now, when I am planning to put a toric IOL, say the numbers are reversed for some reason, I will choose an input data of my anterior curvature numbers. I will not use the numbers of the TCRC. I will use my data value of my anterior curvature. But when I am looking at the orientation of the axis to be implanted in, I am going to keep this difference in mind and use the axes of the total corneal refractive power for the best results of toric IOLs in these patients. Okay, so let's taking this further. This is binodal. So I'll just go ahead and put a traditional positive spherical aberration because now if I'm going to add a negative spherical aberration, I'm actually increasing the spherical aberrations in the patient's eye. I want to keep it as close to 0 and a little negative. So with a minus 0.5, I'm not going to add anything more to it. But the same patient, other eye, is giving me an astigmatism of 1.7 on my anterior values, is giving me a 1.8 on the total corneal refractive power and a difference of 17.1. So this is definitely something that I want to go ahead and correct because 2 astigmatism is significant. So I will input in my formula these values, but the axes will be of the total corneal refractive power, keeping this difference in mind. Now, The other thing that we also want to make sure is sometimes you will have your total corneal refractive power which is less than 1 and only the anterior curvatures could be high. In that case, you do not want to do toric for that patient at all if there is a discrepancy between your anterior and your posterior, and especially when your total corneal refractive power is less than 1, then you do not and you want to avoid toric IOLs for these patients.
Dr. Jenin, just a question. Does the total corneal refractive power means what we have TK on these optical biometers? Does it include
No. Your total corneal, so let's say you have EKR values, okay? That is your EKR Ks that are there. The net power of the cornea will always be -1 diopter less than your EKR values. Okay, so that is like a set thing on the penta. So if you have, say, the net power of the cornea will always be -1 diopter. These are the powers that you want to look into when you're trying to assess the case or you want to use it for a formula. Why do you want to use these values? Because the formulas are still in the old fashioned way. So when you are using the values in the old fashioned, that is they are not yet incorporated. I cannot be saying old fashioned. They are still suited for the older generation formulas. So your case has to be used like this. In this format, you do not convert it into the net power of the cornea. Okay. So this is a patient who has a corneal astigmatism of 2.2. Again, you have a spherical aberration of -0.5. So this particular patient has a single peak, which we see here, and we would do a toric IOL. Now, if you are possibly able to get a non-aspheric toric IOL, then that would be a better choice for this patient than an aspheric toric IOL. Now, this patient, if we see, has got a decentered ablation in the profile, and you see the Ks are all over the place. So it is a K that goes from 38 to 52. Looking at the EKR values of 38, 41, and 40, these values are still different and do not differ by a 0.5 diopter. Now, this particular patient, even after cataract surgery, is someone you want to give a red signal to that you will be dependent possibly on glasses and we cannot give you the optimum results that you're expecting. And your visual quality will always have a little bit of blur. The other reason for that is also that this particular patient has a very higher order aberration of 1.4. So it is a completely bad cornea. There are a lot of
You're mute, Jenin.
and pre-operatively counsel this patient for a residual refractive error and the possibility of not having optimum vision output. So now looking at other topographers, not so because we're talking of all the topographers that are present. So if you have a value like this of a spherical aberration of 0 of 0.18. Now I have a choice of -0.17 or -0.27. I would choose -0.27 because I want to make the patient a little bit more negative spherical aberration. Again, in this particular case, I'm going to look at the spherical aberration in the Z40 plane. And looking at this value, you're then going to decide whether you want to keep the value as 0, -1.7 or -27 and choose the IOL particularly for the patient in that respect. So very clearly your choice of IOL, very simple. If it's a post, you have to do a traditional lens. If it is a post-myopic LASIK, you have to go ahead and do a spherical aspheric lens with the maximum negative power, which is necessary to give the patient a slight residual negative power. And the other patients, you can decide whether you want to do an aspheric or non-aspheric depending on the patient's spherical aberration. Can I just quickly go get the chart? You also come to dry eye. I'll quickly get the charger. One second.
Also, I think we'll wind up in next 10 minutes or so. If there are any queries, we can just quickly have a discussion. So probably, I mean, this EKR holiday is being under, most of the people actually don't have it. The older Pentacams people have not taken it, and it's an updated software, but mainly it helps us to make the choice in terms of irregularity and aberrations of the cornea. I think it just refines your choice of multifocal lens, and if you want to look at the asphericity. So myopic eyes, post myopic Lasik eyes with a negative spherical aberration, that is why lenses like Technis work better. Isn't it, Dr. Vijay?
No, it would be the other way around. Post hyperopic LASIK, Technis would work better because you're making it actually prolate, more prolate. Post myopic, there would be more oblate. So here the choice would actually depend upon what kind of LASIK that the patient has undergone and what is the Q value on the cornea at that time.
No, tell me, but that's my Jenin, post myopic LASIK.
So post myopic LASIK, you want to use an aspheric IOL. Whether you want to use an aspheric IOL of minus 0.17 or minus 0.27 will be decided on your spherical aberration value. Okay. If you are doing a hyperopic LASIK, those patients are already going to have their spherical aberration in the negative value. So then putting in an aspheric lens for that patient is going to make him more aspheric. So you want to do a traditional IOL with a non-aspheric IOL for this patient. So a spherical lens with a positive, the ones that we have routinely with no asphericity.
No. I'm confused. If we are doing an hyperopic LASIK, aren't we making the cornea steeper in the center and flatter in the periphery, right?
That's right. So you're making a cornea more ectatic, right? So whenever you're dealing with more ectasia, you're going to be making a hyperprolate. So it's going to go in the more negative range.
So it's going to be more aspheric. So it's going to be more positive.
It's going to be more negative. Your spherical aberration value will be more negative. More towards the negative.
Which is different in the Q value. Now, Q value is asphericity and the spherical aberration is different. The SA value and Q value, we always get confused between these two things, isn't it?
Okay.
Okay.
Achha, I think let's wind up because it's 9:40.
So, yeah, I think so. Dry eye, I think everyone knows about the importance of dry eye in topography. So I think, yeah, we could just, or do you want to go through the slides? I think we can wind up. I'm good to wind up as well.
If you want to show something like quickly,
we can have a part 2 again.
Yeah.
Yeah, that should be good.
Is high astigmatism 3 and 4 even though all maps are normal? Pooja, you want to ask it yourself? What's the question? I can't understand. It will be good for patient and doctor.
Hello?
Yeah.
Yeah, go ahead, please.
Ma'am, if the astigmatism like -3, -4, even though all maps are normal, is patient is this a normal for a patient in a long run if we perform a LASIK?
Yeah, absolutely. You can go ahead and perform a LASIK for only cylindrical powers. Given that all your maps are normal and given that you're not seeing anything else, they do extremely well even in the long run.
Okay.
So, yeah, we do not definitely want to avoid dry eye. I'm not going through all this, but Yeah, it's just that your Myers, your Placido disc picks up dry eye much better than any other thing. So you will pick up your dry eyes over a Placido than a slit lamp as well. I think we have discussed most of these aberrations. And yeah, if there are any questions, I would be happy to take. Only I think I can sum it up by saying that you want to look at higher order aberrations and cord mu when you're dealing with multifocals. You want to look at your SA values when you're dealing with the basic post-refractive surgeries, and normal patients, you want to decide depending on your angle kappa, cord mu, and your spherical aberration.
Yeah.
Okay, thank you.
Thank you so much, yeah, for such a lovely, exhaustive session. Do we have any quick questions? Though I was handling all your chats and answered most of your questions there also.
Thank you so much, because I didn't look at any.
And I wanted to send you some water or some juice in between. So sending you some virtual because you were at it for 1.5 hours. But thank you. And I think we should keep doing this one topic series at least once a month. It's good to focus on just one topic. And it's quite informative. So thank you everyone for joining in, and thank you so much, Jenin, once again.
Thank you everybody. Thank you, Parul, for the opportunity.
Thank you.
Thank you, ma'am.